we know that the heat helps the effect of the chemotherapy when it comes into contact with cancer cells. And also, again, heat alone can have some effect, cytotoxic effects, so helping cancer cells, die.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Pamela Lu. Pam is a surgical oncologist and the clinical lead of the James Hyperthermic Intraperitoneal Chemotherapy Team. Abbreviated as HIPEC, this is a complicated, state-of-the-art surgical procedure for advanced cancers in the abdomen that utilizes heated chemotherapy during the surgical procedure. Pam will fill us in on HIPEC and how and why it leads to better outcomes for patients. Welcome to the podcast.
Thank you so much.
So I thought it would be good to start with a kind of bigger picture view on cancers in and around the abdomen and peritoneal and why they're hard to treat, which will lead us into HIPEC.
Sure. So a lot of the cancers that we think about that arise from the GI tract can start in, the appendix and the colon, but at a certain point, if they've progressed far enough that they spread to outside of the bowel from which they originated in, they can seed cancer throughout the belly. So if you picture your belly as, a container that all your organs are situated in, floating around in, there's actually a lining in the belly and also a lining on the surfaces of all that organs that we call peritoneum. Once cancer kind of spreads farther along beyond the GI tract, it can seed the lining of the belly. So it can cause small spots of tumor to grow, attach onto the lining, both on the abdominal surface and also on the surfaces of all their organs.
So this lining, the peritoneal lining, help me visualize it. Normally, how thick would it be, and sort of what does the cancers look like? Are there little pinpoints that grow and a lot of them, or what is it like?
So the lining normally is pretty thin. It's, if you picture like a layer of saran wrap on top of some food, it's like the saran wrap that you can peel off. But once cancer kind of sticks to it, seeds it, it can look like a variety of different things depending on what the cancer itself originally looked like. It can look like little tiny white spots throughout the lining. It can be raised, it can be flat. Sometimes different cancers can cause tumors that are harder to kind of peel off as they grow into the lining a little bit more firmly, or certain tumors can cause kind of a mucousy tumor that spreads throughout the belly that can be more scraped off or burned off.
So it sounds like, I'm trying to think ahead, that of problems that if someone has a lot of these spots, and that if you start removing bits and pieces of the peritoneal lining, that could, it wouldn't hold anymore. Is that sort of the problem?
So the peritoneal lining, you can actually remove a lot of the peritoneal lining on the abdominal surface. A bigger problem is if you have a lot of tumor that actually affects a lot of the organs on the inside. So surfaces of the organs, there are certain times when the tumors are a little bit looser, gently adhered, and we can remove those easily without having to remove multiple different organs. But in certain cases, if the tumors are a little bit more aggressive and are more adherent into different surfaces of different organs, there is a limit to how many organs and how much of each organ we can remove in surgery.
Wow. So that it sounds like a complicated, intense surgery that requires great vision and technical dexterity.
It's kind of an operation where you have to be comfortable kind of working in almost every aspect of the abdomen and different organs that are in our abdominal cavity.
So obviously you are comfortable doing that. And that leads us into HIPEC. But from what I understand, it's sort of a two-step process, with the HIPEC being the second step of the process. So kind of walk us through the procedure.
Sure. So anytime we think about surgery like this, we kind of think about it in a few steps. The first step is when we get into the abdomen, we take a full survey of how much tumor there is in the belly.
You do this before, so through scans, right? You have a pretty good idea, but not perfect.
So we have some idea through scans. We know that, the scans and what we actually see inside the belly with our eyes are not always correlative, and oftentimes images like CT scans, MRIs tend to underestimate the tumor burden inside the abdomen, because like we said, those little tumors that can be on the lining inside the belly, they can be very small, they can be very flat, and unfortunately CT scans, as good as they are now, still can't pick those up. It's not quite as detailed enough to pick up something that's maybe like 1 millimeter and flat throughout the abdomen. So for folks that we think are good candidates for a cytoreductive surgery with HIPEC, the first step is to open the abdomen in the operating room and to really take a look to see how much tumor there is throughout the abdomen. And we do have a scoring system that kind of helps different surgeons standardize the tumor burden that we see inside. So, if I do an operation, I have a scoring system that clearly describes how much tumor is in what part of the abdomen, and then that can help other surgeons kind of understand and know what we've seen. And also, it also kind of helps with the scoring system think about how much surgery a patient will need, what their anticipated postoperative and survival will be like after.
When you say a scoring system, is it like a 1 to 10 or 1 to 100, and it's kind of what is it?
Yeah, so it's called the PCI score, or the peritoneal carcinomatosis index. And the way it was designed is it divides the abdomen into 9 areas.
Oh, okay.
And then in each area, you can score based on how much tumor and the size of the tumor that you see from 0 to 3. And then additionally, the small intestine is broken up into 4 segments as well. And each of those 4 segments is also scored from 0 to 3. So you go through and systematically look at how much tumor there is, apply the score. If it looks like in the abdomen, the amount of tumor that is there is amenable to being completely removed with surgery, including removal of any organs that we deem necessary, we proceed with cytoreductive surgery. So that basically just means we go in and surgically remove all visible tumor that we can see with our eyes, and that's the goal.
Is that what cyto means?
Cytoreduction, basically like reducing the mass of tumor.
Okay.
And again, the goal is to remove all visible tumor that we can see with our eyes. And if any residual tumor remains, we want it to be very small, less than like 2 millimeters in size. And once that aspect is complete, that's the cytoreductive surgery part of the kind of greater operation, then we proceed with the HIPEC. So the hot chemotherapy bath, we basically put tubes in, kind of set them in the abdomen. We have a special perfusion machine that both allows the chemotherapy solution to circulate throughout the abdomen, making sure that all the surfaces get contacted with the chemotherapy, and also maintain the temperature, because the H for HIPEC is hyperthermic, so hot chemotherapy. That helps both potentiate the effect of the chemotherapy that has on any residual cancer cells, and also heat itself can also help kill cancer cells.
How hot is the chemotherapy?
So our goal for the chemotherapy solution is about 42 degrees Celsius.
That doesn't sound that hot. Oh, wait, Celsius.
Celsius, yes, exactly.
Ooh, help me. What is that Fahrenheit? That's pretty
That
hot.
is a great question.
That's like...
It's warm.
Yeah,
But
okay.
we do also keep a very close eye on our patient's body temperature with the help of our anesthesia colleagues during this time, because we, want our patients to obviously not get too hot. So we take a bunch of measures. The anesthesia teams here are fantastic, and they will do things like use ice cooling blankets to make sure that the core temperature, so our body temperature in the operating room, is in a slightly elevated but safe zone.
Why is heated chemotherapy better than just whatever room temperature, I guess?
Right. So we know that the heat helps the effect of the chemotherapy when it comes into contact with cancer cells. And also, again, heat alone can have some effect, cytotoxic effects, so helping cancer cells, die. So both of those are why we have the chemotherapy solution heated to that target temperature.
Now, I know there's no such thing as a typical surgery, but in general, it sounds like a complicated surgery. How long can it last from the beginning through the cyto and then through the HIPEC?
So it depends I would say largely on how much tumor there is in the abdomen. For folks who have a lower range of tumor burden, that part can just take a few hours. For folks who have a really high tumor burden, that can take, 8-10 hours just to get all the tumor out.
So one patient a day can be your entire day, and
Yep.
that's an exhausting day.
Yep. But, I think when you're in those situations, you kind of lose track of time. You kind of just go through and with the goal of just kind of getting the operation done.
Yeah, that is true. When you're in that zone, in something you love doing, the time does go by quick.
Yes, exactly.
We're going to take a quick break, and when we come back, we'll talk a little bit more about how and why this is such a beneficial treatment for patients.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Dr. Pamela Lu, who gave us a great overview on HIPEC. So let's dig into a little bit. How long has HIPEC been around, and how and why does it lead to better outcomes for patients?
Yeah, so HIPEC's actually been around for many decades. A lot of the original work was done in patients with GYN cancers with peritoneal dissemination. Historically, the complications that came from patients who were treated with this extensive surgery and hot chemotherapy was very, very high. But as, these types of operations become more common and, the supportive care, pre-op, post-op, patient selection, as that all improves, the post-operative complications, morbidities are actually improving as well. So it's becoming less of a, mother of all surgeries type thing.
It's interesting in talking to you and others how surgery, which you would think is pretty cut and dried, but it's not, and how it advances so much in techniques and better outcomes.
Yeah, absolutely. I think, as we kind of do more and more, the most important thing is looking at our data that we can collect, trying to pick out the patterns that, suggest that patients might do better. There are a lot of clinical trials that are going on too, so it's an exciting time to see where this field will continue to head.
So it seems like, I'm guessing that applying the heated chemotherapy directly to the area where the cancer is better than getting an IV where it circulates throughout the whole body. But why is that? Why does it work better when it's specifically in the right places?
So specific to tumors that are peritoneal tumors, so the ones that are, in the abdominal cavity attached to the lining, the traditional chemotherapy that folks can get for cancers through your IV seems to not penetrate that space as well, so it doesn't seem to affect peritoneal disease as well as it would, say, a tumor inside the liver, a lung mass or something like that. One of the benefits of the chemotherapy, the HIPEC that we do intraoperatively, is that it provides direct access. It's washing the surfaces where the tumors are or were directly. And because of that kind of peritoneal barrier, we're able to give very high doses of chemotherapy directly to the surface, and your body doesn't absorb it the same way that it would, traditional chemotherapy through your IV. So you limit a lot of the toxicity that you would see with, a traditional chemotherapy through your IV. So things like, hair loss, sometimes, your blood counts might respond negatively to things like that. So we're able to give a very high dose directly to the surface that isn't as well accessed by systemic chemotherapy, and your belly kind of prevents it from it being so absorbed that you can avoid some of the systemic toxicities that you would see with traditional chemotherapy.
So this is a very complicated surgery that requires a lot of experts, and I guess this is another example of why a comprehensive cancer center / hospital with a large staff of experts is where patients want to go for this procedure and when they have this type of cancer.
Yeah, absolutely. I think one of the most, amazing things about working at a place like this is we have such a great group of clinicians who are really well experienced in treating these kind of rarer cases. The medical oncologists, radiation oncologists, the pathologists, again, going through some of these rarer kind of tumors that kind of can arise from the peritoneum or seed the peritoneum. Really knowing what the pathology is critical, and having very experienced gastrointestinal specific pathologists is really, really helpful. And our radiologists are very good. They're used to looking at folks with peritoneal dissemination of disease. And again, that can be, like we were talking about earlier, a little bit difficult to try to really estimate how much tumor there is, but having radiologists who are really experienced in this type of patient population is very helpful. And that, not even just the kind of clinicians or doctors that we work with, the folks that kind of help care for all the patients along their treatment journey, whether it's in the outpatient clinic, the patient care resource managers who follow these patients throughout, whether they have systemic chemotherapy first, throughout their months-long kind of post-operative recovery. These are folks who are incredible resources for patients. They help take care of not only the patient, but also the patient's family. When anyone's going through a cancer diagnosis, cancer treatment, they're not the only person affected. And I think the resources that this comprehensive cancer center can provide is a huge help to anybody kind of going through this type of, pretty major life-changing diagnosis.
Yes, definitely. And I'm kind of curious, in med school and residency, you and every doctor has a lot of options. What pointed you in this direction of surgery and specifically this type of surgery?
Yeah, I think, I've always been somebody who really liked the immediacy of surgery. I liked being able to work with my hands and have a kind of immediate result from surgery rather than, some of the more medical types of subspecialties where things are a little bit less immediately gratifying. In terms of oncology, I was lucky to be able to rotate on surgical oncology services in med school and in residency, and I really like the kind of longitudinal relationships that these surgical oncologists were able to maintain with their patients. It's after surgery, it's not like just see you later, goodbye. Right. There is surveillance, there's follow-up, and you really get to know folks for a long time, which is something that I find really gratifying. Also, kind of one of the things that we talked about, the teams that we work with in oncology, with all the different subspecialties, the multidisciplinary tumor boards that we have, which are meetings where, all these specialists from different fields come together to talk about a patient all at once to figure out what the right step is. I think that is an aspect of surgical oncology that I really liked. I like working with other people, kind of picking their brains about what they think is the best thing. So all of that really kind of made surgical oncology make sense for me. And then in training, between, residency at Brigham and Women's Hospital in Boston and MD Anderson, where, they have one of the highest volume HIPEC surgical teams in the country, really being able to see what the kind of most extreme cases are like, getting that exposure and getting, the opportunity to be taught by some of the most, experienced CRS HIPEC surgeons was really, really eye-opening. And I thought this is definitely something that I'd want to do. So
you have that specialty at another comprehensive cancer center hospital, mm-hmm. and you came here about a year ago. Mm-hmm. What brought you here? What was the opportunity that you really liked? I think one thing that's super unique about the James right now, it's an amazing comprehensive cancer center, but it's really in a phase of growth. It is year over year, you can see that we're just continuing to grow our capacity, our volumes, our experience. We have that new building that's opening up really soon. It's a very unique place in time where there's a ton of potential. And I think that's, one of the greatest places to be, especially when I'm starting off practice. But I also have, the expertise of senior surgeons, senior medical oncologists that are there to kind of help work with, give advice, things like that. So I think it's a really, really unique place to work, and there's this really exciting time. And you're not the only member of your family who's a surgeon here.
That's right. Yes, my husband is one of the neurosurgeons here. He actually did a year of training here before staying on as faculty, and he got to see firsthand, how amazing of a place the James is to work. And I think that was a big part of his decision making. And obviously, I think, the benefits that we as faculty get from working in such an amazing place kind of is throughout all the different disciplines of folks that work here.
So I'm kind of curious, with two surgeons as a couple, do you compare techniques and strategies and training?
Yeah, I think as a neurosurgeon and as for him
it's
and
very
belly surgeon for
different,
me, I hope that we don't kind of cross into each other's territories, otherwise something has gone a little bit wrong. But I think in general, being able to talk about the kind of typical day-to-day things is always really nice to have a sounding board that's kind of knows what you're talking about, but not so into the same amount of things. I think it's nice to have that kind of sounding board at home.
But also talk about some other things not related to
Exactly.
to work.
Yes, exactly.
So I like to end this with asking why you do what you do, but you sort of already answered that when you talk about being part of a team and your patients. But maybe expand on that a little. What motivates you to continue to learn and do more and more for your patients?
Yeah, I think one thing that's really exciting about peritoneal surface malignancies or HIPEC is that these are patients where years and years ago, if you have cancer that's spread all throughout your belly, folks would be like, oh, I'm sorry, this is not something we can treat at all. You just kind of go home and deal with the consequences of your disease growing. But I think with the advances that we're making, more and more kind of this stage 4 metastatic cancer in this category is becoming something that is kind of managed, where we have different types of treatments. There are a whole different host of types of chemotherapy that we can apply through the belly in different ways, not just with cytoreduction and HIPEC, that it's really exciting. And I think we're kind of moving away from the this being a end-all terminal diagnosis, there's no hope. I think being able to shift our perspective a little bit on how we approach these patients and kind of hoping to move things towards more of a management of a chronic disease rather than having it be just, a devastating, life-ending diagnosis is really exciting.
Yeah, that's interesting because you're in the early stages of your career, and over the next few decades, you're going to be part of the advances that are going to get to what you're talking about, making it a manageable disease that's not terminal.
I hope so. Yeah, again, it's a really exciting time. There are a bunch of clinical trials that are going on. We have some trials here kind of looking at different ways to manage, again, tumors that have spread throughout the belly, and seeing what techniques we can use to kind of just treat the tumor, manage the tumors, and extend, the length of somebody's life while maintaining quality of life, because ultimately that's extremely important.
Yes, that is very important. And thank you for sharing all this very interesting and up-to-date information on HIPEC.
Of course. Thank you so much for having me.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.